Assalamu alaikum. Now we can start our afternoon session. Welcome. Again, I am Dr. Sami Bahlas. Welcome to the Satellite Symposium by Lilly. Today we have two excellent speakers. The first one is Dr. Osama Hijji, who will talk about JAK inhibitors. Can we differentiate? Dr. Osama Hijji is a senior consultant rheumatologist at Al Muassat Hospital in Dammam. He is associate professor at Ain Shams University, Egypt. Also, we have another speaker from Germany, Prof. Rick Alten, who will talk about Olumiant result above and beyond. Prof. Ricky, she is the head of Department of Internal Medicine and Rheumatology, Schloss Park Clinic University of Medicine in Berlin, Germany. Welcome. Now we start with Dr. Osama Hijji. تفضل دكتور أسامة.
بسم الله الرحمن الرحيم. بسم الله والصلاة والسلام على رسول الله. I wish next time will be more larger group away from Corona. I wish the best of all of you. It's a great pleasure to me in this meeting, and it's my dream day for me. Presentation, please. So today in Saudi Arabia we have 3 JAK, and worldwide there is 21 molecules for JAK inhibitor. Which one of them is effective? Which one is safe? Which one is suitable for you? And can we differentiate between all of them? Everything related to this presentation, it's my own slide, away from few slides from Eli Lilly Company. We have a headache, yes. We are lucky generation of rheumatologists. Why? Because we have a lot to do. We had different biologics. We had 11 biological agents, 5 TNF, 5 IL-6 inhibitor. How we can judge exactly what we can do. But the story is different now because we have 5 JAK. So we have 5 IL-6, 5 TNF, and 5 JAK inhibitor. How we can choose between all of them. And by the way, I arrange alphabetically between 5 of them. So just very hints about this slide, which is the specificity. For biological agent, it is highly specific because if you are targeting TNF, it will reach TNF. If we're reaching IL-6, it will exactly use different. That's why we have 5 IL-6 with the same molecule, but attacking the receptor in different way. But in JAK inhibitor, for me, and for clinical trial, it is variable or low specificity. But interestingly, why I'm looking for this? Because the manufacture cost of this medication, in contrast to biological, is very low. That's why the future will be for JAK inhibitor. It's difficult to have, but we will concentrate on 3 points. The first is the preclinical one. The second is head-to-head clinical trial, and NMA, which network meta-analysis of all JAKs. So preclinically, we have 4 JAK. JAK1, JAK2, JAK3, and JAK4, which is called TAKE2. But the story is not simple as is. If you are combining STAT, which is STAT 1, 2, 3, 4, 5A, 5B, and STAT 6 with 4, JAK1, 2, and 3, TAKE2, what possibility you will have? You will have an 1,260, 96 possible reaction. So to have luck, specificity to any combination, it is something theoretically at least in 2021. But the future will be for this. Ladies and gentlemen, colleagues, we should lead the markets. What does it mean? Somebody will say, we are selective to acting on your right-hand side. This is the way that we are reaching T lymphocyte, and should keep ourselves away from the right side of the slide. What does it mean? If you are inhibiting interferon, there will be herpes zoster. If you are infecting JAK2 inhibitor, there will be anemia. That's why it's difficult to have. But the story is not like this. Please concentrate on the lower and left part of the slide. We have a clinical trial for what? RA, alopecia areata, atopic dermatitis, spondyloarthritis, IBD, a lot of indication, clinical trial. That's why step back by FDA to evaluate what is JAK that will be used for all this generation. All this, including vitiligo-like planus, it means that the future will be for JAK in the next 5 to 10 years. But this slide is very important to me. For me, it is difficult to say it is selective. Forget this. It is something inscientific. There is nothing called selective any JAK. Why concentrate on this? For this classification, they classify baricitinib and upadacitinib as JAK1, JAK2. Both of them JAK1 and JAK2. It is difficult for any JAK to inhibit single tyrosine kinase or JAK in general. And the second, this is a new molecule in phase 2. It is acting on TEC2, which is JAK4, but still acting on different JAK, JAK1, JAK2, JAK3. That's why the side effect will be nearly overlapping with each other. So I will concentrate on FDA. What FDA say? FDA say that Bari is JAK1 and JAK2 in a very clear message. JAK1 and JAK2, it is Bari. What about the other? The other story is different. It depends on how you analyze this. In your left-hand side, if you are by biochemical assay, you will say that UPA is false selectivity for the JAK1. Yes, but if you are changing the experiment to the right-hand side, engineered cellular assay, it will be less selective. So it depends on how you are measuring selectivity. Again, it depends on the cellular pattern that you are looking for. Monocyte is totally different from B cell. That's why you have to concentrate on daily clinical practice. This is a price. You can search the net, Google. You can search for any prescription information for the 5 JAK. 5 JAK worldwide, $1,000 from my own pocket if you find the term selective JAK1 or 2 or selectivity. There is nothing mentioned there. For UPA, it is there. It is not. It acts mainly on what? It's acting mainly on JAK1 and 3, more than JAK2. What about filgotinib, which is the most, they are saying most selective? It is inhibiting JAK1 and JAK2. There's nothing called selective JAK1 worldwide, even by FDA. So this is, until now, this is separated. Everyone is analyzing to each other. What about comparing all together? This is the first abstract that this is presented in the last meeting of EULAR, by Ian McInnes, which is the currently president of EULAR. They are very interesting clinical trial. For the sake of time, I don't know that you see this. They are concentrating on IC50, which what is a concentration that should depend or inhibit 50%. What about the concentration time? What about how you can compare of all of them? Interestingly enough, I will say JAK2. Who is acting with JAK2? Acting with JAK2, all of them is acting with JAK2, which is the more selective filgotinib, which is a very weak. If you are comparing your left-hand side, this is Bari and UPA. UPA inhibits JAK2, or JAK2 combined with TEC2 more than Bari. And again, if you are looking for JAK2 or JAK2, TEC2, it is the same inhibiting more than Bari upadacitinib. So both of them are acting, even upadacitinib inhibit more. That's why for any concentration curve, the beauty of JAK inhibitors that it can inhibit for a short time. What does it mean? Within few hours, everything is going out of the plasma and the blood. It is only exposed for 1.5 hours. If you are like to stop the medication immediately, everything will back to normal. If the patient develops side effect, everything will become back to normal. You can make adjustment of this, but by any means, if you are looking to the curve, all of them inhibit to different cytokine profile. That's why the conclusion, please concentrate based on IC50. UPA was the most and Velcro metabolite least potent across JAK2, TEC2 dependent cytokine, JAK1, JAK3 dependent cytokine, and how we can choose between UPA and Bari. This is a very challenging presentation. We have head-to-head clinical trial. That's why I asked Dr. Ernest in the morning. We have no clinical trial worldwide, and I don't like clinical trial between both of them. Why? We have to forget competition. We are, as a rheumatologist, we have 24 molecules of non-steroidal. We have a lot of medication for beta blocker. We have calcium channel blocker. All of them are acting. That's why we should keep variability of the patient. The patient may respond to one, the another, keeping in mind that we should catch all of them to lesser price. But if you are comparing all JAK worldwide, all JAK is non-inferior to adalimumab except two, which is Bari and Uba. For baricitinib, this is RA-BEAM trial, and you can see in a very important comparison, this is not head-to-head clinical trial, this is just cross-evaluation, that about 10% of the patients selected compare is not biological naive, is not biological naive. Yes, did not expose to adalimumab, but another biological agent. That's why concentration-wise, this is not theoretically good enough to give extrapolation. A patient receiving methotrexate higher dose, the patient is lesser disease duration. So I will say in a very practical way, this is something strange for me that for select and compare adalimumab is not significant difference from TNF or obadasitinib. This is something not strange enough in your left-hand side, but for baricitinib, it is highly significant. Even for low disease activity is the same. Can we shift between both of them? Clinical experience. If you are shifting because of some side effects, please shift on different mechanism of action, efficacy. You may give the patient another chance for another JAK. Network meta-analysis, this is the only way that we can compare between all of them. 1 and 2 for ACR, Bari and Uba, 50 Uba and Bari, for ACR 50 Uba and Bari. This is a very practical way. This is pharmaceutical company sponsored by POP, but this one concentrate on what? The patient with conventional synthetic inadequate response, that it will show no significant difference between all of JAK. What about safety? This is a more recent one. This is published in Mayo Clinic Proceeding. This is ACR 50 responding, HAC responding, herpes zoster. This is the most common side effect. What about upper respiratory tract? All of them is scoring this. What about thromboembolic manifestation? This is a class effect. So class effect for anemia, class effect for herpes zoster, class effect for thromboembolic manifestation. That's why we have to choose. For me, in an honest way, all of them are T. All of them are T. At the end of the day, it is T. But test it in different flavor. Maybe with mint, maybe with cinnamon, whatever it is, but at the end of the day, it is the same. That's why this is, we have to take care how they are promoting. دكتورة، إيه اللي شايفاه في الصورة دي؟ شايفة إيه؟ بسرعة. بسرعة. Yeah. If you are looking for the first time, you will say, how comes birds are eating themselves? No! The mother is feeding her baby. The mother is feeding her baby. That's why we look in details, everything in details, and we have to lead our patient into safer prescription. And thank you for your time and attention.